Hello, hello. Welcome to another Wednesday VMR. Thank you all for joining us. I'm super excited to be joined by one and only Julia. I'm so excited to discuss a case with you, friend.
Me too. It has not been it is actually the first time we will co-discuss together.
I know it's been my loss that we haven't could discuss earlier, but we just gotta make up for lost time. And a big shout out to Ethan and Khashayar for doing teaching points and scribing today. And our case presenter is none other than Nicola. How are you doing, Nicola? Do you want to say a quick hi?
Hi, hello everybody. My name is Nikola. I'm a graduate from the small country of Croatia, currently pursuing a PhD at the Medical University of Vienna, focusing on cancer-associated thrombosis. And I have a new and a fresh case for you all, and I really enjoyed it, and I hope you will too.
Oh, thank you, Nicola. I'm still not over the last case you presented. It was so great. So I'm super excited for today. If we can get the board up, we can get started. All right, Nicola, mic is yours.
All right, so I have for you today a 40-year-old gentleman who presents with 2 weeks of progressive mid-back pain. And I think I'll stop right there.
What a start. So we have a quite young male today presenting to the ED probably with back pain. So with back pain or with any like pain, we should always think about the time course, the localization. Has there been any episodes going on of this pain? Is it like what kind of character is it? Is it more stabbing? Is it dull back pain that does interest me a lot? And also if there are any accompanying symptoms, if the pain radiates. These are all like things I really want to take a thorough history. And also with back pain, there are some like red flags we have to exclude, and they are potentially like life-threatening or have severe consequences. So with back pain, I do think about any kind of neurologic symptoms that can be associated. I'm asking whether the pain radiates until the foot. So is there like neuropathy associated? Is there any bladder or bowel symptoms? So that is something I'll ask and test the reflexes for it. And also like in he is a young male, about 40, can also be a time where like cancers manifest, or early ones. So I'm thinking of a prostate cancer, for example, that loves the bone and can cause osteoblastic metastasis. So I'll definitely ask whether there has been some history, like family history for cancers, and also thinking about like B symptoms. Has there been any weight loss, anything else associated? And also, of course, one very important thing I have not mentioned yet is trauma. So that is obviously a very common cause. Um, yeah, I think it is too early to kind of narrow down it a lot, but these are, I think, the first things I would love to start with. Shameen, what are your thoughts?
Oh my gosh, that was an incredible start to the discussion. I don't have much to add other than I totally agree with you. I think the location is a bit peculiar. You know, we see a lot of lower back pain, we see a lot of upper back pain because of the way spine is made, and like mid back pain, it's a little weird. So that already makes this case intriguing. And I really loved how you were thinking about, the red flag symptoms and also a trauma being one of the most. That's exactly how I think about it as well. And I would say, by the nature of it being an odd place, I'm more inclined to not let go of this back pain. Oftentimes, like if we don't find any B symptoms or like any red flag symptoms, we might be like, oh, conservative therapy. But His location is weird enough for me to want to make sure I have a good explanation as to what. The other thing that I want to just make sure that, it's kind of a midline pain. And as you mentioned, what is a descriptor of pain to make sure we're dealing with like a spine or paraspinal pathology. So first, like, what defining the problem is, and you're right, like 40 is young. And we always say this in VMR that, again, like it depends on who this person is in terms of like past medical history. Kind of like for mid back pain, if I want to do like step one thinking, sorry, system one thinking is like thoracic and like Pott's disease. There's some infections and inflammatory diseases that have a tendency for it. So that is just system one thinking. But for system two thinking is like, okay, who is this person? What is the context that this back pain is happening? What is how long has this been going on? And as you mentioned, are there any accompanying symptoms that makes us more worried for something more sinister or systemic that is going on? So I loved your thoughts. Nicola, tell us more, friend.
Absolutely brilliant points have been already raised. I'll maybe give you some more clues. So, this is a 40-year-old male. He's presenting again with 2 weeks of progressive mid-back pain. He reports that while he had previously experienced episodes of back pain due to his long-standing work in construction, this episode was really distinct in both the severity, which was severe, and the duration of the pain. The pain was once again localized to the middle of his back without any radiation. It got worse, it gets worse on standing up and bending, and it's better when he's lying down and is still. In addition to the back pain, he also noticed that he has to urinate frequently over the last few weeks, sorry. And he also noticed that he gets winded and out of breath more easily over the past year, which ultimately actually led to him having to quit working. And he also has this mild intermittent headaches. He actually hasn't seen his primary care physician for over a year and a half because he unfortunately never had any positive experiences with the healthcare system. But this back pain is really what brought him to the ER today.
All right. Wow. Um, a lot of information, Julia. What do you make of the HPI?
There were very many information that were intriguing, I feel. So maybe to summarize, additional information that's stuck out to me were that the pain was very severe and has not been anything similar before. And just maybe focusing on that symptom for a second, I feel always if you have any kind of very severe pain in the mid body area, I'll say, you have to be cautious if there has been okay, or there could also be a severe vascular issue going on in the background, or any retroperitoneal process, or maybe even an aortic dissection, because sometimes patients are not, or the localization is not always like the same. So that will be something that I would at least love to rule out or have in my back pocket to evaluate on. The second thing I think was very unusual for a 40-year-old is that the urinary frequency over the last few, maybe can you clarify, were the last 2 years or 2 weeks? Like what period of time was it? The
So the,
urinary
the urinary frequency was over the last 2 weeks.
weeks, okay. So that is something that is also very unusual, especially in a man. So of course, I'm thinking about a UTI or any infection or pyelonephritis, maybe asking about associated pain, and also maybe blood in the urine. That's something I would love to dive in further. But it could also be, especially in the combination with back pain, most likely be neurologic sign. So that is definitely a red flag for me. yeah, and hinting towards like neurologic affection here. And lastly, what I feel it is very important, pertinent, negative as well, that there have not been any like inflammatory symptoms like fever or weight loss, anything, night sweats going on. However, the fact that he mentions that the pain is severe when bending, or is severe when lying down. No, sorry, it's better when lying down, sorry. So anything like if the patient is like very calm, that kind of is a hint, I feel, to an either like inflammation or like a structural issue. Yeah, or could still be like a fracture or anything like blocking it. What is very typical, like with when you bend forward, that's something when like the spine there widens in their like gap between, so the nerves do have more space. So if you have like stenosis, that would be something that makes it better, but usually like in older population. So to summarize, I'm worried and puzzled still, but I think these are the ones I want to focus on. So any like vascular issues going on, I would dive in the neurologic signs and symptoms, and I am still worried about still an inflammatory process or any like compressing process going on. Sharmin, help me out here.
You don't need any help, honestly. I think worried, it's a good puzzled and worried. I think it's a very, very fair place to be. Julia, I really loved you invoking aortic dissection as a no misdiagnosis. I think that is fantastic. Mostly because aortic dissections are notoriously hard to diagnose. So having a good spidey sense for it is really, really important. So yeah, kudos to you for remembering that and not really anchoring on just the spine a pathology. And I totally agree with you. I'm not sure how to put this together yet. I think like the mild headache. I don't know if that is like pointing towards a central pathology or that is just like, hey, he's been in pain for a bit now and he has all these things going on. So he has a mild headache as a result of it. But I'll make a note of it. I do think, like as you mentioned, the urinary symptoms is worth investing some time in to better understand it. I don't know as of now if he's having polyuria or is this like more like overactive bladder or incontinence issue that he's like experiencing. So getting some more clarity, and I loved your idea of the UA is interesting. And oftentimes, if this is like polyuria, the labs, like oftentimes it's like sodium and glucose that cause that. So labs will be informative in like helping us make process. However, if this is polyuria, I think like the solutes and also like water, like this is less likely like the primary polydipsia, but like diabetes insipidus has both like central causes and nephrogenic causes. So is that potentially a way of like tying it together? However, ignore that because it's way too early to want to tie things together. So I think like getting a better sense of like, oh, is this a urinary symptom separate? Or as you mentioned, is there something causing the spinal canal to be narrowed, putting pressure on it that is having some urinary symptoms? Another thing, a good neuro exam would be really informative to see if there's any other focal signs that we have to focus more on the spine. Either way, I cannot imagine this patient not getting some form of spine pathology. Spine imaging. And I think I would leave it at that. I think in all comers, especially in 40 years old, um, I think inflammation and infections have interesting way of showing up. And either he's not endorsing any fevers, any chills, but I would have I would worry about if we're dealing with an inflammatory or infectious symptom. So I would keep that in mind again, like for someone, we don't know the past medical history yet, but just given age and like kind of subacute symptoms, that would be something to worry about. And the other thing, with his job in construction, he's just at higher risk of like anything that um, any pathology of spine or like bony get worse by just compression fractures because of the nature of the job that he does. So you can imagine something is making the bones weaker, and he's putting a lot more pressure, more trauma, and it's causing worsening pathology. And I'm really struck by the degree of the severity of his presentation, that this person is no longer able to work. So I'm like really, as you mentioned, worried about this patient. Any other thoughts, Julia?
No, that was amazing. Maybe we can just highlight one or two comments on the chat. I feel people are thinking very hard and helping us out here. I feel one thing Elna mentioned is, I think, very interesting to distinguish, is really thinking about, is it urinary frequency? Thinking about like polycythemia, or rather like incontinence. So that is maybe something it's worth distinguishing. And another beautiful comment I felt from Marie was that with polyuria, you said that as well, as really thinking about any solutes. So thinking about diabetes, glucose, or calcium, and the kidney not being able to concentrate. Despite just thinking about the neurologic side. I think these were beautiful comments in the chat I wanted to highlight.
The chat is just the best. Thank you all. All right, Nicola, back to you.
Just superb points, both from the chat and of course you too. Let me give you some more information. So for the past medical history, our patient has arterial hypertension, type 2 diabetes mellitus, obesity, and also a chronic dry cough of unknown cause. His medications include lisinopril, metformin, and he's been taking ibuprofen for his back pain. For his surgical history, he also had an appendectomy at age of 12. He has a pollen allergy and has had a contact dermatitis reaction to nickel. For his social history, the patient lives with his wife and 2 children. He has 2 pet dogs. Recently, his family members suffer from the flu. He drinks alcohol occasionally, which is approximately 1 beer per week. And he has a smoking history of 1 pack per day since he was 20. His last travel was to Peru, but that was over a year ago. Since then, he didn't travel anywhere. His family history is unremarkable. And let me also give you the physical exam, starting with the vitals. So he has a temperature of 98.3 Fahrenheit, which is 36.8 Celsius. Heart rate of 72. Blood pressure of 133/87. He has a respiratory rate of 18. And on the oxygen, on the pulse oximeter, he has a saturation of 89 on room air, although the patient is asymptomatic at rest. He has a BMI of 30. Generally, he's a patient in no acute distress while he's lying down on the gurney. For the cardiovascular exam, he has a normal rate, rhythm. There's no murmurs or extra heart tones. The abdomen is distended, but there's no pain or palpation. You cannot palpate the spleen or the liver. On lung auscultation, there are bibasilar inspiratory crackles over both lungs. The skin is dry and warm without any rashes. And there's some tenderness on percussion of the spine in around the T6 to T7 level. And the neurological exam is pretty much normal. So normal cranial nerve function, normal strength, normal muscle tone, normal reflexes, a negative Babinski sign, and generally just no focal neurological deficits.
Wow. I love this case so far because I don't know where it's going. And lung enters the chat as well. All right, Julia, what do you make of the background and the exam?
It's such an interesting case, so many thoughts in my mind. I feel to summarize, this young male has an underlying or pertinent underlying disease. So we have a diabetes type 2 in the past medical history, hypertension. I think that are the most striking ones. And also the no fevers, that is great. The other thing that strikes, of course, are the lung findings. So he says 89% on room air, and we do auscultate crackles bilaterally. So what came to my mind, to be honest, just thinking I really want to know the hemoglobin and the calcium, because I do just like some reflex thoughts. We're thinking about like diseases like granulomatous diseases or even multiple myeloma, just because we have the combination of like bony disease, maybe like signs of hypocalcemia with the polyuria and lung findings. So that was just something I would really love to like. Yeah, I'm very curious what the labs show. But besides, it's more, I have so many thoughts in my mind. I feel I have more like interesting questions I want to evaluate on, like, yeah, really looking at the labs, at the calcium level, at the hemoglobin. We do need imaging of the lung for sure. And I think that is just something here. There's so much tension in the room. I feel, yeah, as I mentioned, any kind of granulomatous disease are in the room now. So I would check, sorry, so thinking about even like a sarcoid or TB can always do anything. So I feel the space is so wide at the moment, that I'm curious to get more information on the labs. But maybe you can help me a little bit to put some structure in what we got.
Yeah, no, you are thinking about it the right way. It's really hard to know what is the center of gravity of this case, right? Because you have a patient who's like coming in with like history of like diabetes and like metabolic risk factors, with kind of this like subacute, this is like chronic cough in the background, and now subacute worsening of like lower back pain, urinary symptoms, and who's like hypoxemic on exam. I found his like lung exam very fascinating, with the bipassal crackles. When you think about like crackles, right, like you're like, it's a water. We're not really getting a flavor that this patient has like heart failure or like volume overload. However, you always want to think about that. And then I think just given the chronicity of that cough and the fact that he's like totally asymptomatic, sitting there setting 89%, makes me wonder if this is more like an ILD type picture. And those things tend to take a long. It takes them a long time to develop. This is someone that I would just like for fun would see if they have any like clubbing as well, and oftentimes that is also another sign that you can say like, oh, this has been going on for a while now. But like in the world of ILD, like there's the alphabet soup. If we follow that train of thought, I always like think about if there is like external triggers or internal, and then I leave the radiologist to help me better describe it. But, you know, oftentimes, as you mentioned, like infections are a good trigger for them. And also, you know, autoimmune diseases is another one that can both cause like, you know, some like spinal pathology, back pathology. And again, I think that is like a one thing, especially that's with the T6, T7, really think about like the granulomatous diseases, as you mentioned, TB, like POTS comes to mind. And that cough, as soon as like Nicola said cough, that was started to bother me. I'm like, why is this person coughing for so long? So I think like whether you're dealing with like an indolent infection or like indolent, like a more granulomatous process, I think is a really, really good thought. We still need to have we still need to keep the urine symptoms in mind because we're not 100% sure what is causing that as well. Is it related to the spine pathology or not? But I am worried, like for him in terms of like his hypoxemia. I'm like really worried about like parenchymal, more like interstitial lung diseases at this time, and I would definitely get a CT chest to better evaluate that. And with like hypoxemia, you know, yeah, I would just leave it at that. I think with this presentation, I'm most worried about like parenchymal lung diseases. And the point tenderness, I think over T6, T7 buys you spine pathology, whether that is like bony tenderness, are we dealing with like some amount of like osteo there? And if there's any cord abnormalities, that would like also help you. I really loved your thought of like, oh, what are the electrolyte abnormalities like hypercalcemia or something else that would explain the polyuria? I think that's a fantastic thought. And, you know, whether, and I think, you know, we're backing that like kind of our buckets of like, is this kind of a malignancy without smoking history? Uh, Potentially that like kind of invokes your cancers, invokes like some vasculitides that I think is less likely. And also, you know, he's like with his diabetes, he is like a little bit immunocompromised. I don't know how well controlled that is, but like, you know, endemic infections like TB is another one, as you mentioned, to think about. So yeah, I'm curious, and I hopefully like lab and imaging would help us like chest and back to make a little bit further progress here. Any other thoughts, Julia?
No, that was amazing. Thank you so much. Well, I was also like thinking the diabetes in the background. He's not too young, but it is still a young age, and being immunocompromised with like T cell defects, having in diabetes and neutrophil defects a little bit as well. So there could also be like a spinal abscess going on, but it doesn't really explain the lung finding, which are very pertinent here, I feel, in there in definitely in the foreground. And also like what just one thought I have, but it is more a question for you, is when we think, for example, about multiple myeloma, for example, having our or thinking about bark mnemonic, which start with B for bone, and would follow with A, anemia, and thinking about whether the anemia alone can also contribute to the low SAT, but that does still not explain the inspiratory crackles, and I think the saturation is too like severe. But I'm very, very curious what comes next. So Nicola, please
Yeah,
enlighten me.
Julia, that was amazing. Yeah, I think like I love how you were thinking about like, oh, the anemia. Yeah, anemia usually causes dyspnea. It really shouldn't cause hypoxemia. So yeah, but yeah, and I think from a clinical reasoning perspective, and I have a patient like this, I try not to lump when I don't know what the problem is. So I would just like keep all of them separate and then try to have my Venn diagrams of like, okay, what are the overlap of, you know, this ends up being like kind of ILD, like parenchymal disease and like the spine pathology, the urine, is there a link between them? Or, you know, people don't read textbook, they have like multiple issues going on at once. So I really love how you were thinking about it. Like I think it's always good for us to try to find a unifying diagnosis. However, especially in the beginning when we still don't know our problem well, is to like keep them separate so we don't prematurely close. All right, Nicola, back to you.
All right, amazing thoughts. So as you're in the ED, you of course draw some labs and send those in, and you do really notice that this patient is just excessively thirsty, drinking all the time and going to the bathroom. That's just something to point out on the side. So the labs come in. He has a hemoglobin of 13.1, which is basically normal. The platelets are at 500,000. White blood cell count at 10.6, which is slightly elevated. Normal would be 10.1. There's a neutrophilic predominance. There's no blasts. Actually, a blood smear was also sent out and it came back just completely normal. There's CRP of 27.6. The sodium is at 150. Chloride of 106. Potassium of 4.0. There's a creatinine of 1.1. His last creatinine was from 2 years ago, which was 0.9. ALT is slightly elevated at 41. The normal would be around 30. AST is again also slightly elevated at 71. Normal would be again around 30 to 20. ALP is elevated at 542, the normal being around 150. Gamma GT is normal. ENR and PTT are normal. Calcium, phosphate, and PTH levels are normal, as well as a PSA. Glucose is slightly elevated at 110. They also sent out troponin T and NT-proBNP. These were, again, within normal limits. And a chest X-ray was also made, which showed some unspecific bilateral interstitial infiltrates.
It just keeps your case just keeps getting better and better, Nicola. Julia, what jumps out to you?
So the labs definitely revealed a lot and not everything I expected, I think. So to summarize, we do have a thrombocytosis of 500, elevated CRP, so some inflammation is going on, elevated sodium, and a high level of alkaline phosphatase. That is, to summarize, the lab abnormalities in this case. So, I mean, first of all, I think interesting that we do have an elevation in CRP because we weren't really sure if there's an inflammation or an autoinflammation going on. So I would still be also interested in a BSG in German, at least it is. Sorry, and also we can think about a PCT about just excluding any like abscess formation in the spinal area. That would be something I would be interested in. So signs of inflammation. So it's concentrating next on the sodium. It's elevated. I'll first would love to exclude or think about any kinds of if there are any hints that there's not enough water fluid, so it's just like obviously if he's peeing a lot, that can be just a sign of low volume status in this case, so I would not make a lot of it. The liver panel is also very interesting. I mean, we do have a striking elevation in ALP that can be from like the bone, the liver, or also the placenta. So in this case, I would likely think about the bone. But AST and ALT is also elevated. AST over LT, so that is still be a sign of liver injury. In comparison, like we do have an distended abdomen, but the liver was not palpable, so there has not been any signs of hepatosplenomegaly where we can think about like underlying disease in that area. So I'm curious where this liver injury comes from. and not have like a certain hypothesis at the moment. I mean, he does have a type 2 diabetes, and taking metformin that can also increase the liver enzymes a little bit, but I would not account it, and definitely have to keep it in my like back pocket to think about it. Next, I think what's worth discussing is the elevation in platelet count. So if we have a thrombocytosis, we can really think about it being either like clonal or reactive. And that kind of depends. So if we have like other cell lines affected, or it's very high, we more think about a clonal process. But in this case, also because we do have an inflammatory sign, so an elevation in CRP, it can be just reactive. So it could be due to a cancer, for example. Usually it's more like a solid cancer than liquid ones, or compared to liquid ones. But also like any signs of infection, especially like subacute infections, can lead to an elevation in thrombocytes. One rare cause with thrombocytosis we can always have in mind is anemia, but he has a normal like hemoglobin, so that's something we can exclude. And also no signs of like, for example, splenectomy. So to summarize, I feel we have we have is an inflammatory signal, and that is pretty much, I think, the main takeaway. And also the like bilateral infiltrate is nothing that surprises me after the auscultation, but it does not really help us a lot. So now I'm thinking what I would love to have next. I feel like since do we have more chemistry, so I would definitely check like the calcium, the phosphate, and yeah, that would be still something I would love to check. And then further thinking about our hypothesis, so if there is a cancer, so we should evaluate for that underlying, and also like when granulomatous disease are still in the back pocket, and we still have not excluded any like lung lesion being due to cancer, but so a paraneoplastic process going on due to lung cancer. But still, I think there's so many directions this case can be solved. I'm very curious what you think, Sharmin.
Yeah, I agree. This is a tough one. But as you mentioned, we have our confirmation that we're dealing with inflammatory syndrome, right? With the elevated platelet, elevated CRP. This is an inflammatory syndrome. And we have our explanation of the kind of the urine stuff too. And I loved when Nicola mentioned, like sometimes observing patients, it's really informative that he's like, he just keeps drinking, he keeps sneaking to the bathroom. So like, so such a great descriptor of the polyuria. And now with that sodium, so he's hypernatremic. So like kind of like quick approach to hypernatremia. I often think about like, is there an access issue? And this is what I see most often in our patients with dementia, for example. It tends to be like, they're too confused. They don't know how to drink. They've lost their thirst. They don't have access to water. And then often then after that is like, why are they losing water? And you see in like burn victims, like significant GI lysis, and that kind of like diabetes insipidus. And this is what I would say for this patient. This is like most likely we're dealing with diabetes insipidus. And then last one is like, we're doing it to the patients is oftentimes like increased hypertonic intake or like valproate acid toxicity can do it. So I think this patient probably has diabetes insipidus. And when I think about diabetes insipidus, you think about both central and nephrogenic causes. And for central causes, anything from like a brain tumor to like kind of meningitis, encephalitis type picture can do it. Certain malignancies can do it. With nephrogenic, oftentimes like, electrolyte imbalances, medication side effects can do it as well. So in someone who has some spinal pathology that we're concerned about, I am more worried about like central cause in this patient. And I think the answer lies in that getting a better imaging of the spine and the chest, especially if you look at that liver pattern of injury. Yes, AST is elevated, yes, ALT elevated, but what is most striking is that alk is so much more elevated as comparison to everything else. With a negative GGT, it really, really points to bony pathology, or like in a pregnant woman placenta, which this person is not. But so I think like getting that spine pathology and also getting a better imaging for the chest bilateral infiltrate. And with someone who is coming in with like this chronic cough, pulmonary symptoms, a thoracic spine pathology, hypernatremia, I think this month my theme is like roll out tuberculosis. And I think this is a person that you just gotta have to roll out TB because it just smells, as you mentioned, like a granulomatous disease. And I think TB with his travel to Peru is like one thing to consider. And so that is like number one that it needs to be ruled out. Once you've ruled that out, and thinking about like other granulomatous processes and also like histocytic processes, malignancies, I think then those rise. But currently, I live in a world of ruling out TB. All right, Nicola, back to you.
Excellent points. Let me give you a bit more imaging. So a CT was made of the head and of the thorax. The CT head was a non-cluster CT of the brain, and it demonstrated a normal ventricular size and configuration. However, there was a quite curious floating teeth sign, which just sort of means that the bony sockets within which the teeth lie are just severely eroded. And actually, the patient also mentions that he spontaneously just lost like a tooth like two months ago. The CT thorax was also highly interesting. It revealed pathologic compression fracture of the T6 vertebra without any spinal cord compression. And it showed on the lungs bilateral interstitial infiltrates with upper and mid-zone predominance, along with several multiple cysts and nodules. The claustrophrenic angles were mostly spared. The cardiac silhouette and mediastinal controls are within normal limits. No evidence of pericardial infusion, and there's no lymphadenopathy. And actually, they also performed an MRI scan of the brain, which identified a lesion involving the hypothalamic pituitary sort of area.
Oh, wow. All right, Julia. What do you think?
Find the unmute button. Wow, what another quote. I'm just imagining like the floating teeth sign, to be honest. I'm not completely sure what that means. So I cheated. I just Googled what it means, and when when you ask that, people say, well, it can be associated to Langerhans cell histiocytosis, and that is something that would probably fit also to the lung findings. But one thing I am learning here the most at the moment is that what we always say, do not anchor on like all the diagnoses that come to your head, but try to like establish what the issue here and evaluate it each point by each before like jumping to one diagnosis. I feel the I don't I'm not quite sure what like what we can make out of or completely sure what we can make out of the findings. So we have a lesion involving the hypothalamus axis, so that would probably be a hint that your hypothesis of central diabetes insipidus can be true here. So what we could do is, for example, desmopressin test and also testing the urine osmolarity to just confirm that. That would be something I'm interested in. And besides if we focus on the CT thorax, we have evidence for spinal cord compression due to like a pathologic fracture. So now the question is, what is like the reason for the fracture, and can we make anything out of the cysts and nodules we see? So I'm not quite sure, how to progress much with that finding, to be honest. But yeah, maybe you can help me.
You're doing amazing. This is a complicated case, and floating peace sign. I was this years old when I learned about floating peace sign. But I I think like maybe let's just start with there. So, as someone who's, this is my first time hearing this, but what I would translate it is to what if like, oh, there's something going on with the bones in the jaw that is supposed to hold your teeth together, right? And so what can cause that? I think like severe periodontal disease, that is not my world, but doesn't sound like this is this patient, right? The other things that can do it, like an older gentleman, would be like osteoporosis. Again, not this, most likely not this patient. The one thing that was like a particular with like elevated aquas, if you invoke uh, uh, well, where was the MRI? Like the hypothalamic pituitary axis is like hyperparathyroidism that can cause increase your absorption and weakening of the bones. So are we dealing with like a hyperpara situation? And you mentioned like Langerham. And like Paget disease of the bones are other two kind of systemic diseases that I often think about that can cause like these type of bony weaknesses. And the other one, with the CT thorax, oh yeah. And the other one, like, a scleroderma type situation, again, like, I'm not sure if this is the right demographic for it. So that's kind of like as much I can think about this like floating feet sign. And then thinking about like, okay, how does it relate to the other symptoms that you mentioned? Uh, I think the compression fraction is interesting. And I think from the beginning, I kind of had the hypothesis of like, oh, there's something happened to the bone. And I worry that given his work nature, that caused like worsening of it. And the compression fracture in that kind of setting makes sense to me. But the question is like, what made the bone so weak? Which just kind of goes again with the similar that it invoked kind of a similar pathway as we're thinking about the jaw. At the Langerham cystitis is a really interesting thought. It is quite of a rare diagnosis, and oftentimes you see it more in younger folks. However, I bet you can like see it in a 40-year-old as well. And it really, has the bone pain, the teeth. Oftentimes people have a rash, and the polyuria with the DI, like it's another one to think about. Oftentimes you have kind of lymphadenopathy that I don't see in this case. And I still think like, TB is the one that you need to rule out. I don't think it's a perfect presentation for any diseases, but those are the things that I think about is like ruling out TB, cystitic disorder, and also like think about like maybe hyperparathyroid Paget disease of the bone as well would be the ones that come to my mind. Um, any other thoughts from you, Julia?
That was beautiful. And I really like that you just started to to imagine what the sign means and to dissect it yourself. I feel that was very brilliant.
No, You're too kind. You're a brilliant, friend. Yeah, and I think the last thing that came to my mind, like I think the smoking history, also maybe you see it in patients with Langerhans, and especially with the lung findings as well. So yeah, I think Langerhans was a great thought, Julia. I think for me that diagnosis towards that ruling out TB and then moving to that direction. But yeah, Nicola, I have no idea, friend. Tell me more. Tell us more.
Kudos, absolute kudos and respect to the both of you. You dissected this case absolutely brilliantly. I have just one more slide, one more aliquot. So to just give you more clarity, so I saw in the comments, so the calcium was normal, the PTH was normal, the VSH was normal, and then they tried to biopsy these lung lesions, and they had to sort of, have a few tries at it because it mostly revealed just a non-specific lymphocytic infiltrate. But then they got one with an lymphocytic infiltrate, septal thickening, eosinophils, but also large cells with foamy cytoplasms and prominent nuclei. And on immunohistochemistry, these were positive for S100 and CD1A and placental alkaline phosphatase and langerine. And a diagnosis was made. Both of you mentioned it already. So do you want to give the diagnosis or should I just?
Julia, do you want to take a stab at this? We can maybe dance together.
I feel the lymphocytic infiltrates and also the S100 and so the histo sorry. The biopsy does help a lot to narrow down, so it does sound like Langerhans cell histiocytosis.
Yeah.
Yeah.
Julia,
Exactly.
you are amazing. You got it. All right, Nicola, teach us more.
Exactly. So the diagnosis is systemic Langerhans cell histiocytosis, which involves the pulmonary system, here also the vertebral column, the mandible, and also of course, the central nervous system with the pituitary gland. I have just a few short slides if you guys wanna go over this. This is such an intriguing disease. Let me just share my screen with you all. I hope that you can see it. Let me just go full screen. All right. So Langerhans cell histiocytosis, a long confusing name, but basically it's an inflammatory myeloid neoplasm. So you have both clonality and sort of infiltration of these cells and then inflammation and destruction of different organs. So the neoplastic cells actually resemble epidermal Langerhans cells, but are not exactly Langerhans cells. They actually derive from the precursor cells, so myeloid dendritic cells. The pathogenesis is actually an activation in the MAPK ERK pathway, which then leads to this clonality. It's a very rare disease. It's probably underdiagnosed. The incidence is around 1 in a million adults per year. It's more common in children, however, but the diagnosis can still be made and it still also occurs in adults. It's more common again, so in children, and it's also more common in males than in females due to unknown reasons. There are not many that known risk factors there's isolated pulmonary Langerhans cell histiocytosis, which is really highly associated with cigarette smoking. And this is a disease which basically almost only cigarette smoking people get. There's also systemic Langerhans cell histiocytosis, and it can affect basically any organ, and there's actually no known risk factor for that. So like I said, it can be a single system, and the system that it usually affects are the bones and the lungs, which are the most common ones. It can also affect the skin, and is also the pituitary affection is also quite common. This sort of floating teeth sign is also almost pathognomonic for this disease. And the diagnosis is basically made on biopsy with immunohistochemistry. So this is really such an interesting disease. It's sort of it's really a balance between a malignant disease and a sort of inflammatory infiltrative disease. Because when you think of a cancer, usually you think of this solid mass, but there's no mass here. It's just these few cells which infiltrate different organs and sort of destroy it. So when you have the bone marrow, if you think about it, you have those immature precursor cells, and they then differentiate into our dendritic cells, which are antigen-presenting cells, and then sort of you can find them in our mucosa and in different organs. And if you have this malignant transformation, you have these malignant cells, which then again go on and you can find them again in different organs where they do just basically destruction of tissues. And like I said, you can see the pituitary gland is often affected, the lungs are often affected with these cystic lesions. There's not that many. The differential diagnosis for this severe sort of cystic lesions of the lung it's not that long, and one of the diagnosis is Langerhans cell histiocytosis. The bones are affected and the skin can be affected, and that's all from my side.
Nicola, you're just such an incredible educator. This was amazing. Thank you so much for presenting this case. Yeah, Langerhans histiocytosis blows my mind as a disease entity. And that was fantastic. Thank you for the case and for the wonderful teaching. Julia, any other thoughts before we pass the mic to Khashayar?
I'm very, very grateful, Nicola, that you brought this case. It was amazing. So much learning. I'm excited to read more into it because I don't know. I'm just yeah, I'm so grateful and so happy to have done it. And mostly I'm excited for Kashayar's teaching points now. So please take it away.
Julia, you did such an amazing job. This is a really complicated case. Your discussion was incredible. You should be very, very proud. Thanks again, Nicola. This was brilliant. Thanks, Ethan, for scribing, and Khashayar. Mic to you.
All right. Thank you for such a great case. This is kind of a scary case on reflection. The patient came in for just back pain, which you don't expect to turn out with Langerhans. So let's go and start our approach from the start. We have a patient with back pain, fairly common complaint in the hospital setting. How do we approach it? Initial evaluation calls for a study of time course, localization, special characteristic of the pain, associated symptom, and differences and similarities to previous episodes, combined with the risk profile of the patient, give us a general picture of how concerned should we be about this back pain. There are several red flags that make us more worried, particularly neurologic findings, bladder bowel symptoms, young age, trauma, fever, and the sudden onset of the pain. Usually, spine pathologies are slowly progressing, so new onset of symptoms are very concerning, especially for vascular causes like infarction, or more importantly, aortic dissection, which we've had a lot of cases on VMR, which presented initially with back pain. Now, moving on and zooming in on the patient themselves, we expand first on the location. Mid-back pain is not a typical location for the pains that we usually see. Moving on around the structures, one other structure that we don't want to miss are retroperitoneal structures, which again, aortic dissection comes to mind. Other than that, we are thinking thoracic pathology, infections, and inflammatory. Further moving down the line, the past medical history of the patient makes us concerned for neoplastic and vascular causes, with neoplastic being very close to our mind, especially with the lung findings. The challenge in this case is to combine findings in multiple systems and deciding whether we should approach this case as a singular diagnosis explaining everything, or a patient having as many diseases as they like. In this case, there were several clues that guided us through the final diagnosis. First was the high platelet count and CRP pointing to high inflammation, and then singular ALPs pointing out to the erosive bone disease. Finally, the sodium told us there is something wrong with the brain as well, which the hypernatremia was cluing us to diabetes insipidus because there weren't really any concerns for a lack of access to water in this patient or any iatrogenic cause. So we approached the diabetes insipidus, which could be either central or nephrogenic. Again, there wasn't really any concern for nephrogenic given that the only electrolyte imbalance was the sodium itself. There weren't any specific medications that we were concerned for. And the spine pathology, and especially later as imaging revealed itself, the brain pathology was pointing out to a central cause. Finally, there were some interesting points that we hadn't encountered before. One was the floating teeth sign, which if you go to Radiopedia and read the description of how it presents and the differential diagnosis of it, one of the more interesting ones that I found there was that eosinophilic granulomas can cause the sinus specifically, which in hindsight was something that was pointing the diagnosis to us. And I'm not going to really expand on the Langerhans cell histiocytosis because Nicola excellently taught us in the end. Thank you for such a great case. There's a lot of learning to do.
That was awesome, Khashayar. Thank you so much for distilling down the teaching points. So fun listening to you go through it. Love this case. Thank you also so much for making time for this. Really appreciate you all. Big shout out to Ethan, Nicola, Khashayar, and Julia. See y'all later. Bye.